pleasure of having a new speaker on this show. We have Dr. Praveen Sarda from Ahmedabad, and he's going to talk about the management and assessment and management of stiff elbows. This is an area, again, which uh, is a problem that we come to quite frequently in our clinical practices, and it will be really useful learning from him. So over to you, Praveen.
Good evening, everyone. Thank you very much for your kind introduction, sir. So my name is Praveen Sarda. I am practicing in Ahmedabad as an upper limb surgeon. I'm just going to share my experience of treating this one of the more difficult conditions that I find in orthopedics. So I'll just share my screen. Can everyone see that?
Yes, sir.
Yeah.
It's
Okay.
clear.
Right. Okay. So today we are going to talk about assessment and management of stiff elbow. And as I'm going to talk through during the lecture, there is a wide spectrum of how the patients actually present to us. So assessment is probably the easy part, but management differs widely. All right, so I'm just going to start with a couple of cases to illustrate the variety of presentation that we get. So this patient came to me a few months ago, and this is a 44-year-old lady who underwent an OREF for olecranon fracture about 2.5 years ago. And she actually brought her preoperative x-rays at the time of consultation, and this is how it looked at the time of injury. And subsequently, she's had say about 2.5, 3 months after surgery, she was struggling to move her elbow, and as per history, she'd not been able to bend the elbow at all since about 6 months after surgery. So that was almost 2 years. So as you can see in this video, the elbow is pretty much fixed in extension. She has absolutely no flexion, and she's been really struggling with the activities of her daily living. And this is a dominant hand as well. So this is one presentation. And then in this one, this is an 18-year-old girl who was treated with percutaneous spinning for a radial neck fracture about 9-10 months ago. And subsequently, she developed some stiffness. And this was her range of movement. This was her range of movement when she came to see me. Right. I'm just going to show another X-ray. So we've seen one fixed in extension, the other one with a limitation of range of movement. And this one, unfortunately, I don't have a pre-op video, but this boy had an injury about 2020, as you can see. And it was a blunt trauma at that time, but subsequently he developed stiffness of the elbow. And for almost 4 years, he's had zero movement in the elbow. He came from another city to see me, and this was a CT scan where we can see there was gross bony bridge across the elbow joint, but the olecranon also looked very abnormal, and there was suspicion of malignancy as well. So I'm going to talk to you about these cases again later during the talk, but this was just to give you an idea of the variety of presentation that we see during our practice. So why is elbow prone to stiffness? As I'm sure we've all experienced during our practice, any relatively minor injury can also cause some stiffness, which takes a while to recover. And obviously, if somebody needs surgery, the risk is that much higher. So it is probably the most unforgiving joint in the body in terms of stiffness. And probable reasons maybe because it's a highly congruous joint, and it has a relatively higher propensity for developing heterotopic ossification. Again, there are multiple theories as to why that is the case. And one hypothesis is that because it's a common capsule for multiple articulations, so as you may recall, the elbow capsule actually encompasses 3 joints, the ulnohumeral joint, the radiocapitellar joint, and also the proximal radioulnar joint. So whether that is a reason for the higher propensity for stiffness, and obviously in terms of surgery, there is always that risk of neurovascular damage because there are peripheral nerves in close vicinity, and I'm sure even after years of practice, this is one complication that we're all always concerned about. So sometimes I feel that may lead to a slightly I've put defensive practice there, but maybe that's not the right term. It just leads to we are a little bit more reluctant in terms of exploration, and that may sometimes compromise the outcome as well. So fortunately, shoulder can compensate a lot of elbow movements as well. So there is a reasonably good functional arc that we have. So if somebody has movements from 30 degrees of flexion to 130 degrees of extension, 30 degrees of extension to 130 degrees of flexion, they can pretty much do all their activities without any hindrance. So that is a good functional range to have. And even with about 50% loss of pronation supination, most patients won't have any functional deficit in their daily life because they can compensate a lot through their shoulders. Now, as you will probably guess, the loss of extension is far more problematic than the loss of flexion. So the first lady we saw in this series, the one with the fixed elbow in extension, she has much bigger functional deficit because she can't get her hand to her mouth. So eventually, the role of shoulder and elbow both is to place hand in space wherein we can use it for our daily activities. So you can appreciate that we have a spectrum of findings when you see these patients in the clinic. It can range from terminal flexion extension restriction. So somebody with a very severe tennis elbow pain may also present with a stiff elbow. But then it is up to us to determine during the examination and differentiate the pain inhibition from a true stiffness. So it can range from terminal flexion extension restriction to loss of functional range of what we saw in the previous slide, to an extra-articular bony bridge where it's an heterotopic ossification, but the actual joint itself is intact. And in very severe cases, patients can also present with fusion or ankylosis, as we call it. And mostly this is in cases of unchecked systemic arthritis type of cases. So really, in terms of our clinical practice, what we want to do is differentiate between painful limitation and true stiffness, because this will have an implication on the outcome and what treatment we can offer to the patient. So broadly, I divide the etiology into intrinsic and extrinsic. So the intrinsic causes of elbow stiffness are related to mostly articular incongruity. This may be due to a previous trauma or a previous surgery. It may be due to osteoarthritis, like the progressed osteoarthritis, or rheumatoid or any other systemic arthritis. Loose bodies are also common in kind of terminal cases of osteo or rheumatoid arthritis, and many a times these can cause locking of the elbow. And these are the best cases to get in terms of giving an outcome. The patients are ecstatic after you remove the loose body. The extrinsic causes of elbow stiffness relate to capsular contracture. Again, there are multiple reasons for that, but mostly related to prolonged immobilization or indeed a blunt trauma to the capsule which went unrecognized initially. Heterotopic ossification, again, is a very common cause. Ligament contracture, or sometimes there may be even implant impingement post-surgery, which can cause the stiffness, and these ones also do relatively okay after implant removal. And some cases will have a mixture of both extrinsic and intrinsic causes. Clinical assessment of these patients is actually relatively easy compared to other elbow clinical examination, because in true stiffness, the ligaments are almost always intact, and your clinical assessment focuses on two parts, which is the history part and the examination part. And I would add that when you are doing the examination, what we should eventually be trying to figure out is how this is affecting the function of the elbow, because what we want to do is to restore the functional movement that the patient needs so they can go about their daily business. In history, you want to know what is the, if any, there is any history of injury, or what is the mode of injury, if that is the case. Duration of symptoms are important. The shorter the duration, the better the prognosis in these cases. Polyarticular involvement. So many a times patients may come primarily to us as orthopedic doctors. And if they have polyarticular involvement, then we need to be thinking in along the lines of systemic arthritis, do the relevant workup, and may need to send to rheumatologist early on if they are diagnosed or newly diagnosed systemic arthritis. Any history of previous surgery? If so, obviously we'll be looking at the scars and all. If there was any biopsy done, so for the boy I showed with the fixed flexion contracture, that boy already had a previous surgery in the form of biopsy to rule out malignancy. So it's important to know, because obviously it will also help with the planning of your incision, etc., if you're going to go ahead and operate on some of these patients. Head injury is important to know because these patients have a higher propensity to develop heterotopic ossification, and head injury patients typically have a shorter time to fracture unions. And so this is an important history that we should elicit in cases of polytrauma especially. Always look for peripheral nerve status, especially ulnar nerve. It's not uncommon to see many patients, especially in tertiary level practice, being referred with a stiff elbow, but they also have a concomitant neuropraxia of the ulnar nerve, sometimes due to impingement from the bony bridge across the elbow. And it's important to document preoperatively, also for medical legal purposes. And then you want to know if there are any plates and screws already in there, because if you have an X-ray like this, then it is self-explanatory, and actually the patient can probably expect a good outcome after you just remove the implants and not doing anything else. Coming to the examination part, I personally use a goniometer to document the exact range of movement, and that is helpful also post-operatively, because stiff elbow is not a kind of case where you operate and forget. As in, you need a closer follow-up, you need perseverance, the patients also need to keep patience in terms of outcome, because it's not going to be a quick fix. So sometimes it helps if you tell them, look, this was your pre-op range of movement, this is your post-op range of movement. Yes, it's not normal, but it's much better than before. So it's positive reinforcement for the patients as well. We should always document, like any joint, how much is the active movement and what is the component of the passive movements that you can get afterwards. And there's something which you cannot quantify, but it is soft versus hard feel. Again, for almost all the joint examination, this is something that I find useful, because it tells you of how much improvement you can expect. Sometimes patients with a soft endpoint, wherein it's not very rigid when the elbow comes to a stop, these patients, you can expect a better range of movement after even any intervention, be it stretching, physiotherapy, or surgery, compared to somebody who comes with a hard endpoint, because there is a degree of muscle fibrosis that is already established if the patient has that hard endpoint to the examination. I've already mentioned about the ulnar nerve, and it's important to look for shoulder compensation. So the pronation and supination movements are frequently misreported or misdiagnosed, I would say, because if you are doing them in space, you won't be able to figure out the shoulder compensation. So the correct way to look for the rotations or document the rotations is by putting the forearm on the table like this. And ideally, you can also give them a pen in the hand so they hold the pen and then make them pronate and supinate. So you will know exactly what's the degree of movement without any shoulder compensation. And you look for any previous surgical scars there. So basically, we are trying to find out where does the patient fit in that spectrum, which I mentioned previously. And again, if somebody presents with this kind of picture, this is a 21-year-old girl with a full fused elbow joints in extension. Both her hands were in this position. So it's less about examination and more about counseling in some of these cases. Coming to the investigation, it's important to get a true lateral X-ray, and unfortunately, many times we do not get a proper lateral X-ray, even with trained radiographers. And this is the way to get a proper lateral X-ray. So your shoulder abducted 90 degrees and elbow flexed 90 degrees with the forearm in neutral rotation. That's how you will get this kind of image where both the condyles, like the trochlea and the capitellum, are superimposed in one semilunar picture. And if you have this kind of picture, then you will be able to appreciate any extra articular bony formation as well, which can sometimes get hidden if it's an oblique X-ray. CT scans are useful. This is the X-ray of the boy I showed with the fixed elbow ankylosis. Sorry, this is the CT scan of the lady that I showed first with the elbow in extension. So what we did not see in that X-ray was that there is a bony bridge between her olecranon and between the posterior aspect of the distal humerus medially. So she'd seen 5 or 6 different doctors in that 2 years period, but nobody had done a CT scan. So this thing was missed all this time. This was the reason for her fixed extension deformity. In terms of management, always prevention is better than cure. And I'm sure you're all familiar with these fundamentals, but I'll just go through them to reinforce them again. Still, there are few surgeons who prefer to keep the elbow in plaster for 4 weeks post-operatively. That is not a good idea, especially if it's a comminuted fracture. Try to fix as best as we can. And even if you can allow a limited range of movement, it is better than completely immobilizing them in a plaster, because that does lead to stiffness. This is unfortunately still very common in the community, and it's almost like an accepted practice that it has to be stretched until the pain is writhing in pain. And patients frequently come and tell me कि आंखों में पानी आ जाए उतना तक उसको मैनिपुलेट किया जाता था एल्बो को, but it's not getting any better. That's not a surprise, because particularly in elbow, any forceful movement is counterproductive. There is possibly some internal bleeding that happens and leads to myositis, and it actually promotes stiffness. Then there is after surgery, many a times we just feel and hang on to it that benign neglect, the elbow might get up with physio, with movements, and as the tissues heal up with time. But what I've found in practice is that after the initial recovery period, which is usually about 3 to 4 months, there is usually not a lot of recovery, and we should be thinking seriously about any further intervention that may improve patients' movements. So in terms of conservative treatment, this is especially if the patient has a soft endpoint, this is a good intervention to do, which is a static progressive splinting. These are very basic orthosis devices. Um, Even a hinge brace, for example, is very good in getting extension. You can put the elbow with in the maximum extension position, give it a bit of passive stretch, and lock the elbow in the maximum extension that the patient can tolerate. And you can leave it for 20 minutes, 30 minutes, or an hour, whatever the patient can tolerate, and then just relax it. Doing this multiple times during the day is more effective than one physio session during the day and not doing anything throughout. Because what they will do is in that one session of physiotherapy, at most they can do 45 minutes to 1 hour of exercises, but rest of the day they are not going to do it. So these smaller interventions during the day, which are actually patient controlled, so there is better compliance, there is better pain tolerance, and I find that even after surgical release for a stiff elbow, this helps to restore the movements after surgery. If this fails, then obviously we are looking at surgical intervention, which is based on whether it's an intrinsic or an extrinsic contracture. MUA, unfortunately, is still practiced in some places. I think it's not a good idea in this day and age because, first of all, the elbow capsule is quite tough, and there is a genuine fracture risk with these patients if you do a forceful maneuver during anesthesia. Secondly, after manipulation, even if we manage to stretch them out, there is a hematoma formation, and this can again lead to recurrence of stiffness once the patient is out of anesthesia. So that benefit is hardly ever sustained. And obviously, there is a worsening of heterotopic ossification in these cases if the hematoma forms. So manipulation is a no-no. We should try and avoid that. The next intervention that can be done is arthroscopic release. So in my practice, I found it useful and good results in selected indications only. So if the extension contracture is less than, say, about 30 to 40 degrees, there is a soft endpoint. Loose bodies are the best cases to do arthroscopy for. Or if there is a cases of moderate osteoarthritis in a young patient, wherein we can shave coronary osteophytes, we can shave the capsule of the anterior lower end of humerus, and these patients tend to do better. Short duration of illness and flexion. If the flexion is good, then the result is a lot better. Arthroscopy is not so effective in regaining flexion. It's more effective in regaining extension. This is an important condition. The ulnar nerve should be stable because when we are making arthroscopic portals, and if the ulnar nerve is not stable, it can sublux anteriorly and we may end up causing more damage in terms of neural injury. This is just a picture showing the portals. Some of you may be familiar with this, those who do elbow arthroscopy. And this is just an intra-articular view after doing. This is the anterior capsule which is being pressed down. This is the radial head which is moving, and this is like the final video after I've done the capsule release anteriorly. This is another case, a loose body, and these are the best cases I've said time and again. Relatively easy to do and good outcome with these patients. So there is a bit of, almost always there is a bit of synovitis in such cases, and you can treat the synovitis at the same time when you remove the loose body. So in terms of open intervention or open release, there are some basic commandments that we should follow, and counseling is a very important aspect of the management because elbow releases, you are entering into a long-term relationship with these patients. This is not something that will be relieved in 6 weeks, 2 months, and get all better. Sometimes it may take 4 to 6 months at least for the patients to feel like a substantial difference or improvement compared to their pre-op status. So you should always give them a realistic expectation of what to expect after surgery, and it will help both the patient and the surgeon in the post-operative phase. I always tend to take a high-risk consent in these patients because the surgery does last longer compared to most other surgeries, and there is obviously that risk of a nerve injury with these patients as well. And I always tend to promise less and deliver more. And I guess that is true for everything in orthopedics, but more so in cases of elbow stiffness release. When you're doing the surgery and you've gained a functional range of movement, then you should reassess whether any further dissection is going to get an incremental improvement or not, because sometimes the better is the enemy of good. And if we've restored, say, within 20 degrees of extension, then you can probably accept that rather than trying to go for the whole extension and risk injury to vital structures. Take your time with these operations. These are not something that you want to finish or aim to finish in half an hour and get out. It may take a long time, 2-3 hours is the average time for these surgeries. So thorough pre-op planning, both in terms of anesthesia planning as well as in terms of radiological planning, preoperatively, how you position the patients, etc. So you need to plan all of that. For open release, there is no fixed approach. It really depends on what is the cause of stiffness, where is the heterotopic ossification, whether it's both anterior, posterior, whether it's just one side, medial, lateral. And obviously the previous surgical scars will also dictate the approach sometimes. If there is no scar, I personally prefer a universal posterior approach. And then you can make flaps on both sides and access both medial and lateral aspect of the elbow through the windows in there. However, if you are doing an isolated, say, lateral side and the patient has a fixed contracture, then column procedure is an excellent approach and gives good outcomes. And it's most useful when there is just a lack of extension. Again, coming to the position, it's surgeon preference. Most surgeons are trained in a lateral approach with the arm hanging down, and so they can definitely continue with that approach. I personally do a supine position for my patients for two reasons. One is that many a times I need to do a significant anterior dissection, and I just find it easier to do in supine position. And secondly, if towards the end you need to do a little bit of manipulation to regain the last bit of extension, it's easier to do in supine than in lateral position. If you're doing the surgery in block only and not GA, again, the patients tolerate it better in a supine position than in lateral position. So if both flexion and extension are limited, then usually I found that you need to release both medial and lateral side. Just the lateral side may not be enough. So I'll just a couple of minutes on the surgical approaches. The column procedure, I've already mentioned before, it's more effective for flexion contracture. So basically for releasing anterior column. You can also use the same approach for releasing posterior column. I'll show you in the subsequent slide how. And it's a relatively safe approach as long as you remain in the plane and not lose the plane. So these photographs that I'm showing I've taken from Bernard Morey's book. It's an excellent approach, a chapter on column procedure. And I would recommend everyone to read that chapter if they're planning to do this procedure. So basically, this is the lateral column, the supracondylar ridge. The anterior column release starts on the anterior aspect. The posterior column starts on the posterior aspect. In terms of capsular release, rather than just incising the capsule, you want to take out a wedge of the capsule, because then there is a higher chance that you will retain the movements that you've achieved on table, and the capsule will not heal primarily again. So in terms of muscle plane, you want to enter through the ECRL, just below the ECRL. ECRL is the fleshy part of the common extensor origin, and rest of the common extensor origin is tendinous. So you can enter into that plane. This is how the incision will look. You can extend it down if you want, but usually this much is enough. The fleshy fibers that we see are ECRL, and you can go below the ECRL and retract it anteriorly. You will come across brachialis muscle. Again, you retract it anteriorly. The capsule is just under the brachialis muscle, and that is the plane which is frequently missed. So if you get the plane, it's actually a piece of cake. It's an easy procedure to do, and you can be done within 30 to 45 minutes. I was mentioning about midline posterior approach, which is my preferred approach, because most of the patients, they come with a chronic stiff elbow. Most of them have had a previous surgery and already have a posterior scar from the previous surgery. The advantage is that you make good thick skin flaps, so there is no risk of the skin flap necrosis as such, and you can access the lateral side through the column approach for the superior part. If you need to extend that distally, you can just continue the same fibrous plane along the Cocker's approach and elevate everything as a single sleeve and repair it as a single sleeve as well. Medial side, you can access by elevating the ulnar nerve, and a thin strip of medial biceps is elevated. Then subperiosteal dissection like you would do for a paratricipital approach for total elbow replacement. And both of these can be accessed through the same common skin incision. And one point about extension contracture, as in when the patient is lacking flexion beyond say 90 or 100 degrees, if after all the releases, anterior and posterior releases, you're not getting full flexion, then consider releasing the posterior band of medial collateral ligament. And almost always this will result in the patient getting a full flexion, and it does not result in any instability post-operatively. So this is just a clinical picture of the approach that I'm mentioning. So it's a common posterior approach. This is the ulnar nerve being retracted out of way, and this is the medial paratricipital exposure. And what you see here is the extra heterotopic bone in this particular patient that was present and was excised. In this picture, we see a common distal extension of this lateral paratricipital approach, and we can see the lateral collateral ligament in the depth of the wound there, and if needed you can release a part of the ligament there as well. But the anterior joint can be easily accessed through this interval here. Not sure you can see clearly my forceps pointing towards the medial collateral ligament, which needed to be released in this patient to regain the full flexion. So you'll remember this video from the first patient that I showed. This was all the heterotopic bone that was excised, and we managed to achieve almost full range of movement on the table. Remember, this is 2.5-year-old stiffness, and as I said, sometimes if we've regained good enough movements, then you can stop there rather than trying to go the whole lot. And this was about 10 weeks post-operatively, the movements that the patient had. So for someone who's had absolutely no flexion, to get to about 90 or 100 is a massive improvement in their quality of life. and this girl had a limited arc of movement preoperatively. So we can see it was about 60 to 90 roughly. And this was 2 months post-op. So she has full extension and almost full flexion, lacking in the last 10 to 20 degrees. This was the third case that I showed you, and this patient had his elbow fixed in 90 degrees of flexion for the last 4 years. I think forgotten to mute the volume. So this was third day, post-op day. And he had a reasonable range of movement. Now, there was something interesting in this patient, and the reason I put up this slide here is to highlight there is so much variation in our clinical practice. This boy had slight fluid during his primary surgery, which we sent for culture, did not grow anything. And his wound actually healed all right. But then he developed increasing stiffness about a month after surgery. This was his post-op X-ray. And he came to my clinic almost 6 weeks after surgery with this kind of discharge from his proximal aspect of the wound. We explored him again. He had a lot of cheesy caseating material deep around the in the wound. Sorry. And this was all sent for testing, including gene expert, for TB testing, etc. And everything was negative. Eventually, we had to start him on empirical AKT, and his wounds fully settled down. But unfortunately, he developed an elbow ankylosis in about the same degree. So this was a kind of failure of the treatment. But he had nothing in terms of biochemical markers to suggest that he had any infection or tuberculosis preoperatively. I think we may be running out of time. So what I'll do is there is a video of a nice case of proximal radioulnar joint synostosis. This guy had a head injury. It's an interesting video to see. But what I'll do is probably put the link in the dialog box, and the students can see the video at their leisure, because that's 3 to 4 minutes of video. So proximal radioulnar joint synostosis obviously leads to complete loss of rotations. And again, this can be treated surgically as well. Just a brief word about the literature. After open elbow release, and usually you can expect about 50 degrees, 50 to 60 degrees of improvement in the flexion extension arc, which is a lot in terms of improving their quality of life if they can sustain those movements. However, look at the complication column. So a subsequent complication occurs in 10%, that is excluding the recurrence of contracture. Heterotopic ossification occurred in 14%, and 11% needed a secondary operation to gain more movement. So almost 1/3 of the patients had some complication, and 10% or 11% needed a subsequent procedure. So these are not without risks, and that is why the counseling is so important. This is another paper. This is a meta-analysis and a systematic review of operative treatment of post-traumatic stiff pediatric elbow. This is a very recent paper in the Hand Surgery Journal. And again, you can see that the flexion extension arc is improved to almost 50 degrees. And both the papers and many other papers like that, they conclude that operative management is effective, and you get better results in older children with radial head fractures, and those receiving open releases as compared to arthroscopic release, they are more likely to have a greater improvement. So in summary, elbow stiffness is a difficult condition to manage. Treatment needs to be tailored to the stage of the disease, and in early stage and even post-operative recovery phase, I give them a progressive static splinting for about 6 to 8 weeks post-operatively as well, because I find that is very helpful in retaining the range that you achieved on table. Later stage, we've discussed about the surgical options, and post-surgical outcomes are usually better in flexion contracture than in extension contracture. So somebody whose elbow is fixed in extension, it's almost impossible to get them full flexion after surgery, no matter how good a release you've done. Whereas somebody with even 50 degrees of lack of extension, they can actually get a full extension and retain it as well after surgery. So this is something that, again, you need to bear in mind and explain to your patients preoperatively. Any questions you have? Sorry, just last slide. 4 P's to success in stiff elbow. Practice is one part, surgery is important, and during the primary surgery, as in if you're doing it for trauma initially and then the patients end in stiff elbow, it's important to have develop good planes, achieve hemostasis before you closure, and mobilize the patient as soon as possible. These are not the kind of cases that I would suggest you should take up immediately after post-graduation, because this requires patience and perseverance, both on the part of the surgeon as well as the patient. And physiotherapy is an extremely important aspect of management, the rehabilitation after surgery. However, it's important to keep in close touch with your therapist and reinforce that as far as possible, the movements need to be in the painless range, or just where the pain begins. You do not want to push the elbow in a very painful range. Thank you very much.
Thank you very much, Praveen. I think those were really very important points that you brought out. I think this is not a surgery to be taken very casually. We have been doing a lot of these, and unfortunately, we get these patients with stiff elbows very frequently and have to deal with them. But you really have to be careful. You can cause fractures, you can cause vascular nerve injuries. Sorry, can you hear me?
Sorry, sir.
You can't hear me. Okay, sorry. Can you hear me now?
Yes.
Okay, so
Better.
basically, so thank you very much. That was those are very important words that you brought out, in that these this surgery is something that should not be taken too lightly, because it does have its complications. You can cause fractures, you can cause neural injuries, you can cause vascular injuries, although less frequently, but that's something you need to be also aware of. And what we do is, for any elbow that is very stiff, we always do a ulnar nerve release first. Okay, that's like a routine practice. Of course, if the stiffness is not huge and we are just taking out implants and getting a little bit more movement, then we would stick to the column procedures. But as a rule, even if we don't go on the medial side in terms of the deeper releases, we always release the ulnar nerve if there's a gross stiffness in the elbow joint, because we've had cases where, when we haven't done it, they've ended up with ulnar nerve neuropathy later.
Thank you, sir.
So
Thank you very much, sir.
questions?
Yeah. While we are waiting for the questions, sir, just one thing, sir.
Yes.
Between you have shown both arthroscopic as well as open arthrolysis. So is the similar cases we do it
No.
on either side, or you select the cases for arthroscopy?
Arthroscopies are selective cases, because it will not work in all the cases. It will not work in cases of severe stiffness. And especially if somebody has a lack of flexion, so say, there is no flexion beyond 90 or 100 degrees, arthroscopy, usually they will not get a lot of flexion improvement with arthroscopy, even if you nicely release all the posterior compartment. So in those cases, definitely I'll go for open release only.
I think arthroscopic release is good for relatively mild cases,
Yes.
where there's no gross contracture of capsule, etc. Loose bodies, etc., would be very good indications. But most of the patients that we uh, get are beyond the scope of arthroscopy, at least as it stands today.
I agree, sir. So it is with me.
So, you have mentioned that most of the cases you do by posterior approach. So, do you have any difficulties or whatever, what we cannot get through that posterior approach? What difficulty when you can select dual approach, medial and lateral?
To be honest,
There's
I've not had any difficulty as such. Yes, there is a learning curve to it because the key is to develop good flaps on both sides, and you almost get to the mid-axial plane of the elbow on both sides. But if those are nice thick flaps, I've never seen a skin necrosis. But initially, there is a learning curve to it. I've not had to do a like a double incision approach for a long time now.
yeah.
Only if
So,
something I didn't expect. Say, for example, I went for a column procedure only, and I did not expect that there is a posterior contracture, or I am not able to regain the movements just through the lateral approach. Then yes, I had to do, in a couple of cases, I had to open up medially and do the release. But if it's a planned thing, then almost always you can approach the whole joint through that approach.
yeah, I mean, so any of the cases where they've had previous surgery, have implants already there posteriorly, we would always go posterior. We do tend to, if they've not had previous surgery, or they've sort of, it's been conservative treatment and stiffness, or things like they've been approached medially and laterally and then they've got stiff, then we would consider the medial and lateral approaches. But even from the posterior side, you can get everything. And if you
You can get it.
really are struggling, you can always do something like a trap approach or even an olecranon osteotomy and get round to the front. So there's no reason for saying that you can't get something from the posterior side. I think you can get everything from the posterior side. The only we tend to do the posterior approaches more in the lateral position. That's just a convenience. And if you're going supine and we go medial and lateral, that's how we normally do it. Yeah.
So, when we use like a dual approach, then for anterior part, which one you use, and for posterior, which one, or either side, like
Both.
both the sides, both the approach we can.
Yes.
Yeah.
Yes. Both the side, both anterior and posterior, that we have to do that because otherwise then we won't be able to do 360 release. And one of the problems with the double approach is that you struggle to get to the olecranon fossa from either side unless you really dig into it. And that is one difficulty I found in dual approach in cases of severe stiffness. It's very easy with posterior approach.
So, like as you mentioned about the olecranon fossa, for the olecranon tip, sir, if we need some more extension, we can cut little bit of it. I'm not sure how much to cut. So, what is your
Yes,
take on
absolutely.
it?
Absolutely. You can, when you do a total elbow replacement, it is a part of the procedure to remove that olecranon tip anyway. And you can easily take off the last almost a centimeter, I would say, without any problems. As long as we are not violating the triceps insertion, rest of the olecranon tip we can remove without any problems.
Yeah, there's in fact a procedure which is known as an OK procedure where they
Okay, procedure.
actually excise the tip of the olecranon as well as curate out the olecranon fossa to get enough space for the olecranon to sit inside to get full extension.
Okay,
So
procedures really
I
well
think
for,
those, yeah.
yeah, so
And that also helps in interior cleaning, no, sir? That
correct.
interior
Because we
cleaning.
get a nice window. Yeah.
And sir, I think most of the thing we have covered. So
Yeah.
if there is
Thank
no
you very
question,
much, Praveen.
yeah.
That was great. And we'll hopefully get you again for something. So
Thank you so much, sir. Thank you for your time.
Welcome. Sure.
And I'll put that YouTube link
Sure.
for that case later on in the thing.
Sure. Thanks a
Thank
lot.
you.
That will be great.
Okay.
Thank you very much, sir.
Okay.
It was great, sir.
Thank you, sir.
Thank you. So, let me just put that link on the.
Yes, sir. You can put it here or WhatsApp me, sir, so I can share it in.
Shall I do that? Yeah. Okay, I'll WhatsApp.
Yeah, that's easier, sir. Thank you,
I'll
sir.
WhatsApp you. Thank you so much. Okay.
Thank you so much, sir. It was great, sir.